Welcome to the Ortho on the Go podcast. My name is Chuck Dowell, host of the podcast. This is an educational orthopedic podcast focused on discussing both clinical and functional orthopedics. We will discuss a variety of topics within the field of orthopedics, including reviewing interesting cases, hearing from different professionals throughout the orthopedic profession, and discussing common musculoskeletal injuries and complaints. This podcast is meant for anyone that wants a better understanding of orthopedics, including all levels of practitioners, coaches, parents, and athletes themselves. Hello, everyone, and welcome back to the podcast. My name is Chuck Dowell. I'll be the host for today's episode. Today, we're going to do another case presentation. This is a patient that I saw in clinic recently. This is a 17-year-old female who presented to the clinic with 1 week of non-traumatic lower back pain. She states the pain was worse when moving. She had a throbbing pain at baseline. She states approximately 6 months prior, she had had a similar episode of lower back pain that took roughly 6 months to get better, but did get better where she was able to participate back into sports. She primarily is a volleyball player. She states originally the injury happened back 6 months prior when she was in a volleyball game. She jumped, she felt a pop, some weakness, some pain in the lower back and upper hamstring area. Again, she treated this conservatively. It gradually got better, but then subsequently got progressively worse. She came back to the orthopedic clinic to see me. On physical examination, she had mild diffuse tenderness within the lower back area, primarily the paraspinal area, L3 through S1. Some tenderness was noted directly over the spinous process of L4 and L5. She had noticeable increasing pain with any type of truncal extension activity. Improved symptoms was noted with truncal flexion and rotational activities. So you can see her x-rays on the screen right now. These are the x-rays we took. We took an AP and lateral view of the lumbar spine. It's hard to tell, but you can see, and again, if you're following along on the YouTube channel, you should be able to see these x-rays and the videos associated with this presentation today. My cursor will show you can see a little small defect in the pars here at the L5 level. This makes sense based upon the patient's symptoms. She had noticeable increasing pain with any type of truncal extension activity, which usually causes this type of pain. Subsequently, because this was a repeat episode, she had had it 6 months prior and it took 6 months to improve, we obtained an MRI. Again, you can see on the screen now, I'll push play and we'll kind of roll through the MRI itself. And you can see primarily on one side as we're rolling through here, no disc herniations, good space. But right here, there's increased fluid uptake within that pars area on that unilateral side. And if we can kind of roll back here a little bit, again, you can see right there, there's a good view of that increased uptake in that area. So I think when we define pars fractures, we define them as either spondylosis, which is a direct injury to the pars area itself, defined as a complete fracture of the pars interarticularis, and then that can go on to develop as a spondylolisthesis, which is defined as a forward translation of one vertebrae segment over the other. Now, typically when you see these in clinic, these athletes and or patients are going to present with low back pain. If it is more of a stress reaction type injury, oftentimes it won't be associated with any radiological findings. They could have pain into the buttocks, up into the upper hamstring area. Oftentimes they'll have pain with radicular symptoms, possibly into the L5 nerve root. Pretty rarely they'll have bowel and bladder problems. They'll have noticeable limitations, likely increased pain with truncal extension activities, possibly some limitations with flexion, but flexion may improve their symptoms. They may have some mild provocative symptoms, including straight leg raise, and they may also have an antalgic gait as well. So again, if we look at the graphic on the screen now, you can see that the pars interarticularis is in that posterior aspect or posterior column. This often happens secondary to repetitive stress to the area. Etiology is usually secondary to repetitive hyperextension activities. This is why we often see this in gymnasts, sometimes in other sports as well. So again, the most common high-risk sports are gymnastics, football, diving, wrestling, soccer, dance, baseball, and weightlifting. Baseball is likely secondary to the hyperextension with throwers. There is a peak age. We got to remember that the spine does not finish full maturation until approximately 25, which is oftentimes why we see this in our younger athletes. Typically, this involves the L5, but sometimes can involve the L4 as well. Some of the literature does show that these pars fractures and or possible stress reactions at the area can represent up to 47% of low back pain in this young athletic population. So 1 in 2 athletes that you see and come in complaining of chronic low back symptoms, they could have something similar to this pars interarticularis fracture or a possible stress reaction to the area. Again, we define spondylolysis, as a fracture within the area, and then spondylolisthesis as a anterior slip or a slip on one vertebrae over the other. So again, here you can see via the graphic that when we're looking at these lumbar vertebrae, we have that L5 vertebrae, we have the inner vertebral spaces, which is usually composed of that disc. We have to remember that each one of these levels is a different joint, so there's going to be movement within these joints. Ideally, there's stability within the spine, and that stability is created secondary to these pars area of the vertebrae, which help to make up the facet joints, and the facet joints provide the stability between one joint to the other with these anterior posterior translation that could potentially happen. If there is a fracture within the area, they could potentially have that forward slip. So again, the pathophysiology of these secondary to repetitive lumbar extension, possible rotation activities can be chronic, secondary to stress fracture, microfracture, or reaction within the area. Risk factors include hyperlordosis, tight hamstrings, rapid growth, and early sports specialization. If these athletes are doing only these single plane activities repetitively, especially these extension activities, they could cause increased stress to the area. And again, because we don't have full maturation of the back until approximately the age of 25, this is going to lead to these overstress areas within the lumbar spine. Symptoms: activity-related low back pain, pain with extension, decreased athletic performance. Again, we all know the red flag symptoms we're looking for when we're looking at the lumbar spine. Oftentimes, the initial imaging can just be an AP and lateral lumbar radiograph. We can do advanced imaging. Most of the time, I'd recommend an MRI. Obviously, with the CT scan, we're going to expose the athlete or the young patient to possible radiation. So I think the MRI is probably the preferred modality, especially if you're looking at a stress fracture or stress reaction within the area. The MRI is likely going to pick that up better. Specific findings. So on the x-rays, we're looking for that pars defect. You can see it on the oblique view, or on ours, you can see it on the direct lateral view. Any type of cortical break, that spondylolisthesis, and then that classic Scotty dog appearance that you can often see. So again, you can see on the graphic when we're looking at that lumbar spine x-ray, this is more of the oblique view. You can see the superior articular facet, inferior articular facet kind of meeting transverse processes, and then you can make out that Scotty dog. And if there is a fracture through the neck of that Scotty dog, that could represent a possible pars fracture. Again, limitations of the x-rays are if there's early stress injuries or findings, potentially you won't see those on the x-ray, so that's a clinical exam finding. MRI is the advantage, early detection, especially for those stress reactions. There's no ionizing radiation. Oftentimes you'll see some bone marrow edema, possible cortical injury to that pars area. And then again, with the CT scan, the limitations are radiation exposure. These can be used for surgical planning if we're going to proceed to the surgical planning aspect. Different types of classifications associated with this. Probably the most common classification is really grading the anterior, the spondylolisthesis, and potentially how much anterior translation there is one vertebrae on the other. This is going to quantify possible a non-operative versus operative treatment. Ideally, we want to get them before they get to this place. If they're just in that spondylolysis category, then potentially they can heal quite well and not have long-term side effects. When they get to the spondylolisthesis, the long-term side effects become more apparent. Additional non-operative treatment is often associated with activity modifications, rest from sports, anti-inflammatory meds. Braces are a little bit controversial. Some will do bracing for approximately 6 weeks or so, especially in the acute stress reaction to the spondylolysis, as this will prevent kind of further hyperextension through the area and help to immobilize the area. But again, not always required. Physical therapy often helps quite a bit, focusing on core strength, improve those dynamic stabilizers around that lumbar spine, improve the hip mobility, and then as they're reducing in symptoms, they could potentially return to sports. Again, bracing, variable evidence regarding this. Typically, the brace duration would be 6 to 12 weeks, especially with these stress reactions or these acute symptoms. Return to play. Ideally, the return to play is a pain-free range of motion, the athlete or patient is completely pain-free. They're able to have normal strength and they're able to participate in sport-specific activities without pain. Image healing is not always required if the clinical symptoms are asymptomatic. In our patient, we treated her non-operatively. We brace immobilized her for 6 weeks. After 6 weeks, she had improved symptoms. We started her in physical therapy activities, and she was gradually able to return to sports activities. Here's her x-ray 3 months afterwards. Again, you can see that pars fracture a little bit better on this x-ray. As that bony reabsorption and healing has gone on. We did try to get possible bone stimulator for this patient, but unfortunately wasn't approved by insurance regarding it. As far as operative treatment, surgical indications would typically be failed non-operative treatment, progressive spondylolisthesis. So if they're progressively getting worse, this is where you could get those flexion extension views on the patient to see if there is a progressive or anterior slip, especially positional related slip, that may quantify you for possibly doing surgical treatment. Surgical treatment include direct pars repair. This can be a screw directly across the area. This is best for young athletes without a significant or major slip. And then in some patients, they have to do a fusion as well. This is what that direct repair would look like. So this is the screw you can see right across that pars. This was a unilateral fracture, and they were able to stabilize it. This can possibly have higher predictability as far as return to sports activities. Outcomes are usually quite good. Most of the time, non-operative treatment can treat this quite well as long as they don't have a spondylolisthesis with a significant slip. That would be a grade 3 or more, so more than 50% slip anteriorly. Typically, patients can do quite well with non-operative and conservative treatment. I think the biggest thing to coach is that this can take quite a bit of time for them to get better. It can be approximately 3 to 6 months before they're able to return to sports-related activities. And there's controversial evidence regarding possible not returning to the sport that caused it, not returning to a sport that causes these hyperextension injuries. We do see these in football linemen because of their chronic extension. Again, oftentimes do see these in are gymnastics athletes, wrestling athletes, anything that is getting into the hyperextension. How can we prevent this? Avoid the year-round overtraining, the repetitive stress to the area. Would recommend participating in multiple sports to get uniplanar movements and to develop improved strength. Emphasize core strengthening. So again, those dynamic stabilizers around that lumbar spine can help to protect that spine and get them out of some of those positions. Maintain hamstring flexibility. Again, monitor training volume, encourage multi-sport participation, and proper biomechanics and coaching. some things to remember. Pain in adolescent athletes is not always a muscle strain. Again, some literature reports that these are in up to 47% of patients presenting with lower back pain. So again, possibly every other patient you see in this adolescent group complaining of chronic lower back pain could be one of these. Pain with extension should raise suspicion, again, for a pars injury. So if I put them into that extension position and that's a provocative maneuver for them, I'll shut them down. And if they're not improving, then I think getting that MRI can be helpful. Early diagnosis definitely does improve outcome, prevents it from going to that spondylolisthesis and that slippage. And most athletes can return successfully with conservative treatment. Just in passing, so this is another gentleman I saw. He was a 50-year-old male, chronic lower back pain. He had a pars defect at L5-S1, which likely contributed to his low back pain symptoms. Also developed some significant arthritis at that L3, L4 level above the area. So he presented initially to clinic with a long-standing history of lower back pain. Again, you can see on his x-ray here, there's a pars fracture at that L5-S1 and possibly some early anterior listhesis in that area. These are his x-rays in the flexion extension views. So again, flexion view, leaning back to see if that listhesis is worse, and then the extension view as well. For him, we were able to obtain a CT scan. This is his CT scan on the right here. And again, his was primarily kind of unilateral. So you can see right there, if we go back, that's the pars fracture right there. So you can see the level above and the level that we're looking at. That's our pars fracture there as we're scrolling through. As we get through to the other side, he has a pretty good articulation, no fracture seen, but did have that unilateral pars fracture. Again, we were able to treat him conservatively, and he was able to do quite well afterwards. So I thought this was an interesting case, just kind of one of those things that we see occasionally in clinic, but probably it sees us more often than we see it. Knowing that a large percentage of patients can have this, I think it's important to remember that these are common overuse injuries, especially in adolescent athletes. Extension and rotational loading can be the primary mechanism. MRI can often be useful for diagnosis in these stress reactions. So if you see a young patient in clinic and you try to shut them down and they're not improving with their symptoms, you could obtain that MRI to evaluate for this. May help with the timing of treatment and how long it's going to take them to return to sports activities. Conservative management most often is effective in these patients, and early recognition can prevent progression and possibly chronic problems, especially when they start to develop that spondylolisthesis that could potentially happen. I appreciate you listening to this. I hope you found this helpful, and we'll talk to you on the next one.